بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيد المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. As I have mentioned previously that we will go to talk about different classes of drugs, to talk about their pharmacokinetic manipulation and dosage calculations. Now we'll continue with the second examples after we have discussed the previous example, which is for the aminoglycosides. It will be the second class of drugs, which is the immunosuppressants, which are the cyclosporins and tacrolimus as famous examples. What are the also you should take care that our reference or textbook will be the clinical pharmacokinetic applications rather than the applied pharmacokinetic. What are the measure used for the immunosuppressants? For example, treatment in the cases for transplantation, organ transplantations, kidney transplantation, heart, liver transplantation, or other autoimmune diseases. We are administering the immunosuppressants drugs. Okay. So the objectives of our lesson today, that the student should be able to discuss why immunosuppressants agents, examples for this class of drugs, the cyclosporins and the tacrolimus, why these agents need special dosing considerations. Okay, if we compare it with what we have mentioned previously about aminoglycosides, why it does need special dosing considerations, because it's entirely eliminated by the renal route, plus it has an extreme nephrotoxicity and ototoxicity. So we should take into consideration if the patient is having any renal problems to make those adjustments. So first of all, we should discuss the why the immunosuppressants agents do need special dosing considerations. We will describe the clinical monitoring parameters for these immunosuppressant agents compared with the clinical monitoring parameters we have talked about previously in the previous session for the aminoglycosides, and we will be able to explain the effect of the disease state and patient conditions, renal impairment or hepatic impairment, mainly because they are the most metabolizing and eliminating organs of the drug outside the body, and to explain the effect of the disease state and patient condition on the drug dosing for these immunosuppressant agents. And we should be able to apply dosing determination methods for the selected immunosuppressant agents. How to make dosing determination. In our previous case for the aminoglycosides, we have consider either the conventional dosing technique or the extended dosing interval technique. Okay. Now let's start with cyclosporin. Cyclosporin is a cyclic polypeptide with immunosuppressant properties that it's widely used for the prevention of a graft rejection in solid organs. Okay. Transplant patients, and for the treatment of psoriasis, rheumatoid arthritis, and a variety of other autoimmune diseases. So for cyclosporin as an immunosuppressant agent, it is used either for prevention of a graft rejection. Graft, it is the transplanted organ like kidney or liver or heart or whatever. in solid organ transplant patients, and it is also used for treatment of psoriasis صدفية, for treatment of rheumatoid arthritis, التهابات rheumatism. These are types of autoimmune diseases, the rheumatoid arthritis or the psoriasis. Now, for patients receiving cyclosporin after transplantation, the goal of the therapy is to prevent the graft rejection for this transplanted organ while avoiding the adverse effects of the immunosuppressant therapy. It has wide adverse effects. You can remember for aminoglycosides having nephrotoxicity and ototoxicity. Now we will look about the adverse effects of the cyclosporin. Cyclosporin concentrations should be monitored in every patient receiving the drug. Its therapeutic concentration should be monitored in every patient receiving the drug. The desired cyclosporin concentrations differ according to what's the required plasma concentration. It differs according for cyclosporin, the type of organ transplanted. It's differ according to the time during the post-transplantation phase, immediately after transplantation or longer period after transplantation, and also according to the protocols specific to the transplantation service and institution. The protocols by the transplantation institution or transplantation service, and the time after the post-transplantation phase, and the type of the organ transplantation. According to these factors, these three factors will determine the desired plasma concentrations of cyclosporin. Now, the basic pharmacokinetics for cyclosporin. Cyclosporin is almost completely eliminated by hepatic metabolism, not like aminoglycosides. And the aminoglycosides entirely eliminated through the renal route. But for the cyclosporin, it's not more than 99% eliminated by the hepatic metabolism. Hepatic metabolism is mainly achieved via the CYP3A4 enzyme systems. Okay? There are more than 25 identified cyclosporin metabolites. None of these metabolites appear to have the significant immunosuppressive effects in humans. They are non-effective, these 25 metabolites. Most of the metabolites are eliminated in the bile within the therapeutic range. Cyclosporin follows linear pharmacokinetic. Okay? So it's mainly eliminated through the hepatic route. So any problems in the hepatic conditions will result in those adjustments for the cyclosporin after administration. There is a large amount of intra-subject variabilities in the cyclosporin concentrations obtained on a day-to-day basis, even when the patient should be at steady state. When I'm talking about intra-subject variability, it is within the same subject. Between time to time, within the one day, there is an intra-subject variability. There is a variability in the drug concentration. Okay? There are many reasons for this intra-subject variability within the same subject, day-to-day variations. Okay? Among which is the cyclosporin. Among the reasons for intra-subject variabilities is that the cyclosporin has low water solubility. It's opposite to aminoglycosides. The aminoglycosides was or were highly water soluble with low lipid solubility with a small volume of distribution. For cyclosporin, it has low water solubility and its gastrointestinal absorption can be influenced by many variables. It's not soluble, it's insoluble. For the cyclosporins, we have a high day-to-day variabilities, intrasubject variabilities due to the low water solubility. So food containing large amounts of fat will enhance the absorption of cyclosporin. If the cyclosporin is to be taken with food with high fat content, it will be more absorbed, resulting in higher therapeutic concentrations because it has higher lipid solubility, low water solubility. If the patient does not take food with high lipid content, the absorption of the cyclosporin will be reduced. Cyclosporin is a low to moderate hepatic extraction ratio drug. Low hepatic extraction ratio or moderate hepatic extraction ratio with an average liver extraction ratio of around 0.3 or 30%. The cyclosporin binds primarily to erythrocytes and lipoprotein. It does have high protein binding, yielding unbound fractions, free fractions in the blood that are highly variable between 1.4 to 12%, which is a high variable range, wide range of variability for the free unbound drug in the blood. Okay. The transplantation type does not appear to have a substantial effect on this cyclosporin pharmacokinetic. The transplantation type, whether different types of transplantation techniques, but definitely we have told you previously, I have told you that the cyclosporin concentration will be affected by the type of organ transplanted as well as the time after transplantation during which the drug will be administered and the protocols of the institution or transplantation services. Several methods to initiate cyclosporin therapy are available. Among the most commonly used methods are the pharmacokinetic dosing method and the literature-based recommended method. For the pharmacokinetic dosing method, it is the most flexible method of the techniques. It allows individualized target serum concentration. Each patient can be individually assigned with his dose and therapeutic concentrations according to the parameters for that patient to be chosen for the patient. Each pharmacokinetic parameter can be customized to reflect the specific disease states. Each pharmacokinetic parameter can be customized to reflect the specific disease state and the conditions present in that patient. The other method, which is the literature-based recommended dosing, which is a very commonly used method to prescribe initial doses of cyclosporin. The literature-based recommended, just to look back again with the guidelines, what has been written in literature previously, what has been given to different patients, and to start at least initially with the initial loading dose of cyclosporin with the patient depending on what has been recorded in the literature. Okay, then we should go on with the pharmacokinetic dosing method. To start with the pharmacokinetic dosing method, considering the pharmacokinetic dosing method, the goal of the initial dosing of cyclosporin is to compute the best dose possible for the patient in order to prevent graft rejection. So the goal of the initial dosing of cyclosporin is to compute the best dose possible for the patient in order to prevent the transplanted organ rejection. Now, it will be based on the estimation of the clearance. The patient is categorized according to the disease state and the conditions that are known to change the cyclosporin clearance. Just remember that it is more than 99% hepatic eliminated or metabolized. Okay. Clearance previously measured in these studies is used as an estimate for the current patient clearance rate. Okay, that has been previously measured in these studies. For example, this is the pharmacokinetic dosing method rather than the literature-based recommended method. Okay, an adult transplant patient with normal liver function would be assigned the cyclosporin clearance rate equals to 6 milliliter per minute per kilogram. So if he is 70 kilogram, it will be 420 milliliters per minute. Okay, this is for a normal liver function. You should memorize these values. For a pediatric, not adult, pediatric transplant patient with normal liver function, we would assume the cyclosporin clearance rate to be 10 milliliters per minute per kilogram for pediatric. The above value for adult. A very simple pharmacokinetic equation that calculates the average steady-state concentration is widely used, and it allows the maintenance dose computation. Very simple pharmacokinetic equation that calculates the average steady state is widely used, and it allows the calculation of the maintenance dose. Now, the average steady state equals F multiplied by D divided by clearance multiplied by tau. Okay, D, the maintenance dose, clearance, tau, dose interval, and F, the relative bioavailability. Let us take an example, a case 1. He is or she is an HO. He is HO, 50 years old, 75 kilograms. He's 5 feet 10 inches, male. He has renal transplant. He's a renal transplanted patient. 2 days post-transplant surgery. The patient liver function tests are normal. Take care of this consideration. Suggest an initial oral cyclosporin dose designed to achieve the steady-state cyclosporin average blood concentration that is equal to 250 micrograms per liter. A 12-hour dosage interval is to be used with bioavailability F value equals 0.3. Now, the mean cyclosporin clearance for an adult patient with normal liver function is equal 6 milliliters per minute per kilogram, and his body weight is 70 kilograms. First of all, estimate the clearance according to the disease state and conditions that are present in the patient. So the mean cyclosporin clearance for the adult patient is expected to be 6 milliliters per minute per kilogram multiplied by 75. It will be 450 milliliters per minute. This is per minute. Divide by 60. It will be 27 liters per hour. Okay, 27. We are converting from milli per minute into liters per hour. This is the clearance of cyclosporin in that patient. Compute the dosage regimen, 12-hour dosage interval. We have been informed in the question that the 12-hour dosage interval and F equal 0.3. This will be used for this patient, where D equal average steady state. It has been told that the average steady state will be 250 or 250 micrograms per liter, multiplied by clearance already calculated, multiplied by, please take care of units, Sabaya. Here the clearance is liter per hour. Don't depend on a clearance value as milliliter per minute. This 27 liter per hour is equal to 450 milliliters per minute. But here in the equation we don't put 450 milliliter per minute because the average steady state concentration is in microgram per liter. So we should use similar units. So we converted into liter per hour, and per hour, not per minute, because the tau is 12 hours, it's not in minute, divided by 0.3, so the dose is 270,000 micrograms, or which equal to 270 milligrams. Okay, it can be rounded up to 300 milligrams every 12 hours according to the availability of the dosage form. Now, the cyclosporin serum concentrations would be obtained on the daily basis, with practical steady state expected to occur at about five half-lives, since the half-life of elimination is around 10 hours, so 5 by 10, it will be 50 hours, or around 2 days, which are 48 hours. Okay? By this, we have ended with cyclosporin, and we will go to tacrolimus, which will be very similar concerning tacrolimus, with minor differences. It is another autoimmune suppressant. Concerning tacrolimus, its trade name is the Prograf, or Advagraph, or Protopic. These are the trade names for tacrolimus, which is an immunosuppressant drug that is used mainly after organ transplantation to lower the risk of organ rejection, as well as sometimes it could be used for treatment of certain autoimmune diseases. It achieves this, the immunosuppressant action, by inhibiting the production of interleukin-2, which is the molecule that promotes the development and the proliferation of the T cells, which are vital to the body's immune response. So the tacrolimus will inhibit the production of the interleukin-2 that will promote the development of T cells. Okay? The therapeutic range for tacrolimus used by most transplantation centers is 5 to 20 nanograms per milliliter in blood. Take care about nanograms, which is equivalent to 0.5 to 2 nanograms milliliter in plasma. Why there is a difference between why the value in the blood is higher than that in the plasma? Because there is protein binding in the blood. Okay, so it is 0.5 to 2 nanograms per milliliter in plasma. Please take care about the nano unit rather than the milligram. Tacrolimus is extensively bound to erythrocytes, so its blood concentrations are much greater than its corresponding plasma concentrations. Okay? Just for comparison purposes, if we want to compare the therapeutic concentration for tacrolimus compared with the cyclosporin, as you noticed here, for tacrolimus it is 5 to 20 nanograms per milliliter in the blood. For cyclosporin, just in the previous example, it was 250 microgram per liter, which is equivalent to 250 milligrams per milliliter. Okay, so it is much more higher than that value for tacrolimus. That's meaning that tacrolimus is much more potent medication compared with cyclosporin. Cyclosporin cephalosporin use is safer in use relatively compared with tacrolimus. So to continue up with the tacrolimus, two different assay systems are in widespread use because of its therapeutic and toxic concentrations. To calculate the therapeutic and toxic concentrations for tacrolimus, so we have two different assay systems that are in widespread use to assess or assay the therapeutic and toxic concentrations for tacrolimus. What are these two assay systems? First of all, ELISA, and next MIA. ELISA, an enzyme-linked immunosuppressant assay. This is an assay system to assay the therapeutic concentration of tacrolimus in the blood. The other test, which is MIA, the microparticulate enzyme immunoassay system to assay the tacrolimus therapeutic concentration. Using blood as the assay matrix, these two different assay systems will produce similar results to assay the therapeutic and toxic concentrations of tacrolimus. The desired tacrolimus concentration differs according to types of organ transplanted, time during the post-transplantation phase, as well as the institution protocols of the transplantation services. Now, the basic clinical pharmacokinetic parameters to be monitored for tacrolimus. First of all, we should know that it is almost completely eliminated by hepatic metabolism, more than 99%, very similar to cyclosporin. Hepatic metabolism is mainly achieved via CYP3A4 enzyme system. There are more than 15 identified tacrolimus metabolites. None of these metabolites appear to have significant immunosuppressant effect in the human. They are therapeutically ineffective as an immunosuppressants. There is large amount of intra-subject variabilities in tacrolimus concentrations obtained on day-to-day basis, very similar to that have been noticed by cyclosporin or with the cyclosporin case, even when the patient should be at steady state. There are many reasons for this variability, that again tacrolimus has low water solubility and its gastrointestinal absorption can be influenced by many variables, from which is the food. While oral absorption rate is generally fast for most patients, time to maximum concentration between half and 1 hour, some patients absorb tacrolimus very slowly. Okay, the absorption lag time of up to 2 hours have been reported in liver transplanted patient. Absorption lag time of 2 hours, although most commonly the maximum concentration could be achieved within half to 1 hour after administration. While the average oral bioavailability is around 25%, i.e. 0.25, there is a large amount of variation in this parameter among patients. It could be ranged between 40% to 89%, i.e. from 0.04 up to 0.89. These are the F values. So there is a wide variabilities, either inter-subject variabilities or between inter-subject variabilities, i.e. between different patients. Tacrolimus is a low hepatic extraction ratio drug. In the case of renal failure, the renal failure does not significantly change the tacrolimus pharmacokinetics because, as we have mentioned previously, it is more than 99% eliminated by the hepatic route. And tacrolimus dosage adjustments are not necessary for patients receiving hemodialysis or peritoneal dialysis. Tacrolimus dosage adjustments are not necessary are not necessary for patients receiving hemodialysis or peritoneal dialysis because the patient the drug is mainly eliminated through the hepatic route. Tacrolimus binds primarily to erythrocytes, alpha-1 acid glycoproteins, and albumin. The exact value for protein binding is high, 72 to 99% protein binding. It's very high protein binding for this. Okay. How to carry on initial dosing determination method. Back again, pharmacokinetic dosing method. Pharmacokinetic dosing method. Let us discuss one example, which is an HO patient. He is 50 years old, male. His body weight is 75 kilograms. He's 5 feet 10 inches, male with renal transplant patient. 2 days post-transplant surgery. The patient liver function tests are normal. Back again, suggest an initial oral tacrolimus dose every 12 hours, which is tau value, designed to be achieved with an average steady-state tacrolimus blood concentration, which equals 15 micrograms per liter. Okay, just if you remember, I want to discuss this back again, steady state, which is 15 microgram per liter for tacrolimus. When I have started with slide number 18, I have told you that it is 5 to 20 nanogram per milli. 5 to 20 nanogram per milli. If we took the interrange value inside, which is 15 nanogram per milli. 15 nanogram per milli is equivalent to 15 microgram per liter. Okay, so it's very similar. For this, I am telling you, just take care and consider the units value. Okay, so the mean tacrolimus clearance for this patient is expected to be 0.06 liter per hour per kilogram, and its F value is 0.25 bioavailability. He wants us to determine the initial oral tacrolimus, again considering the pharmacokinetic method for dose determination. Okay, initial dosing determination method, pharmacokinetic method. Rather than the literature-based recommended daily method. Okay. The estimated clearance according to the disease state and conditions present in this patient is 0.06. The 0.06 has been mentioned just previously in the question. Multiplied by 75 kilograms, so the clearance will be 4.5 liters per hour. Then to compute the dosage regimen by the famous equation using the average steady-state concentration, 12-hour dose interval will be used in this patient. The dosage equation for the oral tacrolimus is D equal the average steady-state concentration multiplied by the clearance by tau over F. Then it will equal 15 microgram per liter multiplied by 4.5 liter per hour. The clearance multiplied by tau 12 divided by f 0.25, it will equal 3,100 micrograms, which equal 3.2 milligrams, which could be rounded to 3 milligrams every 12 hours. So the tacrolimus concentrations would be obtained on a daily basis with a steady state expected to occur in approximately 3 days, 5 half-lives, which will equal 5 by 12. This will equal 60 hours.